Well, good morning everybody, and thank you very much indeed for the invitation to come and speak here. It's my first time in the Middle East, and of course that's very interesting for me anyway. It's also a pleasure to talk to paediatric neurologists, because if you're anything like my UK colleagues who are in the paediatric field, you will be very bright, very intelligent, very enthusiastic and very hardworking. So with all those abilities and talents, I'm sure that this field is going to be very well served in the future. So I started with myasthenia gravis, but I'm going to talk about that briefly later on. And I'm very much now involved in antibodies that seem to be causing central nervous system diseases. And we learned from myasthenia gravis that antibody-mediated diseases can be defined usually by antibodies that bind to the extracellular domain of a membrane protein on the target tissue, for instance, the acetylcholine receptor in myasthenia. These antibodies can be measured in the serum. The antibodies cause loss of function, and the patients can improve dramatically sometimes with immunotherapies, plasma exchange, intravenous immunoglobulins, steroids, etc. So antibody-mediated diseases are treatable. That's the most important thing. So the diseases of the central nervous system with specific antibodies that are found in adults and children are rare, but they're immunotherapy responsive diseases. And the ones that I'm going to briefly touch on are Neuromyelitis Optica with aquaporin-4 antibodies, ADEM, and also Neuromyelitis Optica with MOG antibodies, relatively new findings. Then what we call the VGKC antibody, which I'll tell you a tiny bit about, which is a voltage-gated potassium channel antibody with limbic encephalitis predominantly, Nmda receptor antibody encephalitis, and glycine receptor encephalitis. So a lot of different antibodies now to hear about and think about in your practice. So to start with Neuromyelitis Optica, of course this is a disease where you get optic neuritis and transverse myelitis predominantly. Traditionally it was called Devick's disease, and what he described and his colleagues was a monophasic disorder causing simultaneous or sequential optic nerve and optic neuritis and transverse myelitis. In fact, the monophasic disorder may be somewhat different, and the more common neuromyelitis optica is very much a relapsing remitting disease, as you know. The patients were subsequently described with this relapsing form, and often temporal separation between the optic neuritis and the myelitis, which don't necessarily occur together. And is now recognized to be a very severe relapsing remitting disorder of the central nervous system and distinct from multiple sclerosis. So this is largely due to the work of the Mayo Clinic, and in 2004 and 2005 they were able to show that there were specific antibodies in Neuromyelitis Optica, and those were directed against a water channel called aquaporin-4. These antibodies are proving very useful in the early diagnosis and disease monitoring. Excuse me. And in the UK, we're identifying about 1 per million new patients each year. Not so many, but a useful number to remember. So aquaporin-4 is a 6 transmembrane protein. That sounds big. Now that is all. Happened there. Says I've got no power. It looks like in. my fault, but you never know. Give 2 minutes. So aquaporin 4 is a water channel. It's expressed in astrocytes at high density, which is probably important for antibody-mediated diseases. And those astrocytes are adjacent to the blood-brain barrier of the endothelium of the blood vessels. And it seems that these antibodies to aquaporin 4 are pathogenic because if you inject them into animals, you can demonstrate that under certain circumstances the antibodies get lesions in the brain and spinal cord, which are really very similar to those that are found in neuromyelitis optica. So this is a form of demyelinating disease in which there is a highly specific antibody which seems to be causing the condition. You can see how disorganized my life is with all those files. Those are the ones that I haven't dealt with yet. So neuromyelitis optica isn't particularly common in children, but there certainly are some cases, and I'll just briefly go over some of the data. But first of all, how do we actually measure the antibodies? This is worth showing you because this is a way we measure a lot of antibodies nowadays. It's called cell-based assays. So we take some cells and we make them express the antigen we're interested in. And in this case, that green blob is neuromyelitis optica antigen aquaporin 4. And we've told the cells to express the antigen, and we've made them green because the antigen can be tagged with a green molecule. And then we put the patient's serum on, and maybe the patient's antibodies bind, and then we detect them with a red second antibody. So what you see underneath is, on the right, there is a patient whose antibodies have not bound to the aquaporin 4 cells, so you just see the green cells without any red around them. But on the left, the patient has aquaporin 4 antibodies, and you can see the red rim around the green cells. And that means when you look down the microscope, you say, right, that patient is positive. And you can score the binding if you want to be more quantitative. As I said previously, one can show with experiments that the antibodies are pathogenic. So on the basis of being able to measure these antibodies, the spectrum of disease has expanded to include limited and atypical forms of neuromyelitis optica, so the numbers are actually increasing a little bit. So as well as classical neuromyelitis optica, there is isolated or recurrent longitudinally extensive transverse myelitis. You can have isolated or recurrent optic neuritis, and you can have brain or brainstem attacks of demyelination, which are associated with these antibodies. So the antibodies are being useful because they help to define diseases which may previously have been considered different, but which are probably going to respond to immunotherapies. So what about in children? Well, this is a summary of a national survey which was carried out by Michael Absoud and Cheryl Hemingway in London. And you can see on the right the numbers of patients they found in just over 1 year with neuromyelitis optica, ADEM, optic neuritis, transverse myelitis, and clinically isolated syndromes. And you see that, in fact, the total number comes to about 120 that they've identified in 1 year. That's about 2 per million in the UK, but that would be about 10 per million for children per child in the UK. And you can see, as you probably expected, that ADEM is the most common. Optic neuritis is also common, not necessarily, of course, with alpha-4 antibodies, those two. Transverse myelitis is quite common. Neuromyelitis optica in the classical sense is not very common. We've recently done an outcomes study on neuromyelitis optica of all ages in a collaboration with the Japanese group who are very active in this field. And I just thought it was interesting to show you the data on disease onset, because here, in fact, you can see, if you look at the grey, which is the Caucasian patients, the incidence peaks between 46 and 60 years. When you look at Afro-Caribbeans, it's much younger. And the Asians themselves have a slight tendency to be rather more in the lower age groups than you might have expected. And I think one does have to consider that different ethnic groups may well have these diseases at a different rate and in probably a slightly different manner. One of the things we did learn in that study about children is that permanent visual disability is more common when the disease starts early. So this is the age of disease onset in various sections along the bottom, and you see that permanent disability occurs in 50% of patients who started below the age of 16, and that's visual disability. But funnily enough, when you come to motor disability, permanent motor disability, it's rather uncommon when children present with this disease, even subsequently. So that's curious, and we don't know what it means, but it's something to bear in mind. Here's one patient that I'm going to show you because he was rather important to us. We spent a lot of time on this patient. He's a child being seen in Birmingham, and he had high antibodies to alpha-4. He had optic neuritis, transverse myelitis, brain lesions, etc., etc. And you can see that his antibodies are high, and they don't seem to go down with conventional treatments. Azathioprine, prednisolone, even rituximab didn't seem to be having any effect. So we know that can take a little while. But what did work, of course, was plasma exchange. And in this particular child, plasma exchange turned out to be the only way we could keep his antibodies down. And you see that at one stage, or in fact for quite a long time, he was having plasma exchange 3 times a week. But of course, the child wasn't going into school, and he's at this stage about 8 years old, and he's also got partial severe optic problems with really not much vision left. So it's a pretty tragic situation, but we have, funnily enough, found a drug which I'm not going to tell you about because it's certainly not licensed, but it's a monoclonal antibody made by one of the companies which seems to have had an effect on this child, and is now being weaned off all other treatments. So there should be some hope even for these children. But you can see it can be a very challenging disease to try and treat effectively. So in general, it's important to recognize NMO early because permanent disability is more attack-related than it is in multiple sclerosis. So they tend to develop more and more disability with every attack. They don't revert to normal in between. And in children, acute exacerbations are usually treated with 5 days of intravenous steroids plus IVIG, and severe exacerbations are treated with plasmapheresis. And importantly, don't use interferon beta if you think it's neuromyelitis optica because it makes them worse. It's a very different disease to multiple sclerosis. It seems, though, that the antibody positivity is lower in children than in adults, which is rather a pity because it's proved very useful for identifying these children. And even with the best assays, it may only be about half of the patients who have the alpha-4 antibodies among the pediatric cohort. But there are probably some more antibodies to find. And this was a 4-year-old boy who was noted to be bumping into things. This gradually got worse over a few days. And then he developed urinary incontinence, which was atypical for him. And you can see on the left, the imaging, he has some high signal here in the cones, and here it's shown to be enhancing, and there's basal ganglia changes, some subcortical changes, and optic nerve enhancement. So this child had both spinal cord and optic nerve involvement at the same time, relatively unusual in typical NMO. And in fact, it turns out that he has more antibodies. So antibodies to myelin oligodendrocyte glycoprotein. And this is a new antibody that's beginning to be looked at both in children and adults with these sort of spectrum diseases. In fact, the MOG antibody-associated patients so far tend to be younger than the typical alpha-4 antibodies. Patients, there are more males than females. Quite a few of them are children with ADEM, but some of them have a neuromyelitis optica presentation, and that's what you need to be careful about. The myelitis quite critically involves the cones, which is different to typical neuromyelitis optica, and particularly long segments of the optic nerve. But they do seem to show a good response to immunotherapies, and it may be a self-limiting form, rather like ADEM. Basically, it's an ADEM that presents as if it's neuromyelitis optica. So ADEM and other demyelinating diseases, including MS, are found in about 10 per million children per year. The alpha-4 antibodies are not common in children, but can cause early permanent visual impairment. And the MOG antibodies are beginning to be found in some cases, but we don't really know yet. There haven't been any very comprehensive studies. But I think it's going to be useful to measure those antibodies. So now let's go to the potassium channel antibodies, the Nmda receptor, and the glycine receptor antibodies. These are mostly found in adult diseases, but they are proving to have pediatric counterparts. But I have to start with the adults, because those are often the best visible, sometimes. So this is a patient who has voltage-gated potassium channel complex, VGKC complex antibodies. And he has neuromyotonia, which is a peripheral nerve hyperexcitability. This is, as you see it, a purely peripheral nerve problem. It doesn't stop when they go to sleep. And as you can imagine, it does disturb their sleep, or if not theirs, their partners, because partners say he keeps twitching all night. This is a not life-threatening disease. It's relatively benign, but it can be associated with very severe pain, and the pain isn't necessarily muscle cramps, it can be neuropathic, so there is sensory involvement as well as motor involvement. And the sensory side has been rather ignored in the past. But that's peripheral. However, here is a syndrome which includes neuromyotonia, and is called Morvan syndrome. It's extremely rare, but it's very interesting. You have neuromyotonia, autonomic disturbance, and insomnia as the main components. And the insomnia now is a real insomnia. It is not just a result of the discomfort. Antibodies to potassium channel complexes in the majority of patients, and 1/3 of them have thymomas, which are often malignant and or recurrent. And some have previous or associated myasthenia gravis. We've just published 29 cases in Annals of Neurology, and these were collected from around the world, so it really is rare. But in fact, a couple of years ago, when Nina Barisic in Croatia held a pediatric neurology conference, which perhaps some of you were at, she presented one of her patients, who was a 15-year-old girl with myasthenia gravis, thymoma, and Morvan syndrome, all of which got better with immunotherapy. So it can occur in children. Much more common with these antibodies is a form of limbic encephalitis. So in patients with these antibodies, it's usually not paraneoplastic, and the MRI signs are restricted to the temporal lobes, as you would expect. And low plasma sodium is really quite common when you have potassium channel antibodies and limbic encephalitis. The antibodies fall with immunotherapies, and there's substantial improvement. So here's a patient who was not diagnosed until 5 months into his presentation. He was almost unconscious with constant seizure activity, and he had high levels of these antibodies detected. And his antibodies are actually shown right up here. So we don't know when they started or how high they were, but by the time he was diagnosed 5 months later, they were up here, which is very high. Controls are right down here. And you can see how quickly they come down with good treatment. This is a monophasic disease, and once you get rid of the antibodies, they often don't come back, although they sometimes relapse. We have patients who've now been followed out for several years, and their antibodies have disappeared, and they're off all immunotherapies. So it's not a permanent disease. So his antibodies came down, and he improved very substantially. He became alert, oriented, seizure-free, and neuropsychologically substantially improved, although not, unfortunately, completely back to normal. But he lived independently until he died a year or so ago. So these are treatable conditions. They may be rare, but they need to be recognized and treated because the patients can get better very consistently in most cases. So here is a study we did more recently in which we measured, or we asked the clinicians, the neurologists, to tell us what was the modified ranking score at onset and following treatments. And they used different treatments. This was all individual clinicians from the UK and other countries. But you can see that the modified ranking score fell very substantially with chemotherapy. And many of the patients became either normal or only very slightly impaired in day-to-day living activities. And then we noticed that actually there's something else that goes on with these antibodies. So if we just go back, watch the right side of her face as well as her right arm. So this is what we call facial brachial dystonic seizures. And they occur, in our experience so far, only with these particular potassium channel antibodies. And it's usually a prodrome to limbic encephalitis. And we hope that if those patients are recognized and treated, they may not develop the limbic encephalitis and they may not get any of the sequelae of that condition. It's a very steroid responsive form of epileptic, dystonic epilepsy, a sort of combination of the two. We haven't identified any children yet, but I don't believe that there won't be any, although they may be exceedingly rare. It's just an interesting condition. And what's interesting about it, in part, is that the patients show a poor response to anti-epileptic drugs and many adverse reactions, but a good and surprisingly fast response to prednisolone. So it seems to be very steroid responsive, this particular form of preceding prodrome to limbic encephalitis. So potassium channel antibodies I've been talking about, but actually they're not really against the potassium channels. And this was something we had to admit 2 or 3 years ago when we realized that the antibodies were not against the potassium channels, which are illustrated here in the aquamarine blue, but against other proteins that are complexed with the potassium channels. And that's why we call them VGKC complex antibodies now. And one of them is called Caspr2. There's less antibodies against this protein, and antibodies against LGI1. And those of you who know a little bit about epilepsy genetics may remember that LGI1 is a protein that can be mutated in a particular form of lateral temporal lobe epilepsy. So LGI1 is clearly something that controls activity in the brain, and either mutations in that protein or antibodies to it can cause seizures. Morvan syndrome tends to have these antibodies, but not exclusively, and most of the limbic encephalitis and facial brachial dystonic seizure patients have these antibodies. But are there children with these antibodies? When you look at the data from our own diagnostic service and you just see how many patients we're diagnosing with these antibodies, you see that the great majority are males and in the older age range. And there are really rather few patients who are below the age of 20. However, there have been some case reports of potassium channel antibodies associated with forms of limbic encephalitis. This paper from the Germans 3 years ago, where you can see the high signal in the medial temporal lobes. And then the patient subsequently had a bit of hippocampal atrophy. She wasn't diagnosed diagnosed or treated effectively at any stage, in fact, because the parents weren't convinced about it. But she did have a subacute syndrome with memory impairment, affective disturbance, and refractory temporal lobe seizures. And when the antibodies were identified, the parents were offered treatment again, but they weren't convinced, and she hasn't been treated, which is probably a pity. She might have done a little bit better if she had been. So there's a study from Russell Dale in Sydney, in which we were involved, where we looked for the antibodies in 10 children, in a series of children presenting with status epilepticus. And in fact, these were found in 4 out of 10 children who had this pediatric status, age 1 to 14 years. They had no previous histories of seizures. They weren't treated with immunotherapies in the acute stages, and generally speaking, the outcomes were poor, and one developed hippocampal sclerosis. But the important thing with these antibodies is to try and identify them early and treat the patients early, not to wait 2 years and then ask, oh, do they have antibodies? It's too late. And these antibodies, and also occasionally GAD antibodies, glutamic acid decarboxylase antibodies, are present in children with limbic encephalitis in a study from the Germans, which we also helped with, and in a more recent study that we published, which I'm likely to come to at the end, depending on the time. So there's beginning to be a hint that there's some patients in the pediatric cases with potassium channel antibodies, but they're certainly not very frequent yet. However, antibodies and movement disorders are proving to be very interesting in children. And I'm sure you've heard about the Nmda receptor antibody encephalitis, which was described by Joseph Dalmau. And there, in fact, is a new review from Martin Titcherer with Joseph Dalmau's group in Lancet Neurology this year. Initially, they were young female adults with ovarian teratomas and an associated encephalopathy. And the antibodies to the Nmda receptors, as you might expect, bind very beautifully to the hippocampus, where the Nmda receptors are expressed in the molecular layers, as you can see here. That's just an indirect immunostaining. And are measured by us and by Joseph Dalmau, slightly different techniques, but essentially by the cell-based assay that I told you about previously. And here is an example of our antibodies. So here are the green cells that are expressing the Nmda receptor on their surface, and the patient's antibodies are binding around the surface of the cell. Children with these antibodies are relatively common. They're between 2 and 18 years, and in this study from Florence et al., which came from Joseph Dalmau's group, some of them were preceded by infections or vaccinations, which certainly seems to be a bit of the trigger, partial trigger in children, and even in adults from time to time. But the disorders present largely with behavioral or personality changes, seizures, commonly, and a movement disorder. Those seem to be the defining features of this condition. And about 50% of children have some sort of prodromal symptom which suggests the preceding infections or vaccinations may help to precipitate this disease. I don't think they cause it. Some cases have been diagnosed as encephalitis lethargica, and I don't know if that's a diagnosis which is ever made here, but if it is, you have to think about this particular disease. So here's a patient. She presented with neuropsychiatric features, amnesia, and seizures originally, and then, like so many of them, she develops this movement disorder. And you can see that this is a choreoathetoid movement disorder with a lot of orofacial movements, which are very typical of this condition, although they're also found in others, actually. And then this dolly posturing on the left side. And she is really almost unconscious, and yet these movements continue, even in a patient who is consciously not there at all, which is rather interesting. Many young women have ovarian teratomas, but in fact, in our experience, not so many. And she didn't. She was treated effectively. She'd gone back to college. As far as I know, she's still doing well. It can have relapses, but hopefully not too often with the right treatment. There's a new paper by from Joseph Damar's group on Mount et al. And they're looking at 20 Spanish patients that have been identified with the antibody test, and it gives you some very beautifully coloured pictures which describe the various clinical features, and I'm not going to go into it, but you might like to look at that paper. Here is a girl who was certainly not unconscious, but is completely mute. So she was definitely trying to speak, but couldn't, and she was quite catatonic. She was plasma exchanged and given steroids very quickly because she was identified quickly, and she made an absolutely striking recovery, went back to school. So it takes a little while, it's never that quick. She had 6 courses of plasma exchange, and by this stage she's performing normally. I gather that she's doing extremely well at school, and she seems to be 100% back to normal. So it can be an absolutely reversible disease, which is wonderful, but not always. Sometimes there's permanent disability. It definitely occurs in younger children as well. She was 13 at the onset. This is a child from Italy who didn't become unconscious, but you can see how strange her behavior is, and I'm not sure if we have the sound. For some reason we don't have the sound. So she makes strange, almost animal-like noises, very disturbing. And eye movements can be very effective. And here is a child who had the disease for quite a while before it was diagnosed. And you can see the eye movements, which are absolutely bizarre. And this terrible movement disorder, which went on for some time. So she had Csf Lymphocytosis, which is very common in this condition. Not necessarily oligotonal bands initially, but usually subsequently. But the neuroimaging was normal. She had negative infection and neurometabolic investigations. She's given IV and IG and methylprednisolone, but a short course. And there was no real improvement. And it was only when she was tested for the Nmda receptor antibodies did people really think, like, we must treat her more effectively. And as a result, she was treated effectively. And her antibodies, which are in green, came down, although they tend to go back up again. They seem to be coming down steadily now, or at least that was some years ago now. And she did improve, but not to 100%, unfortunately. Here she is 1 year after starting the disease, and she's certainly better, but she's apparently behaviourally not going to be normal, unfortunately. She's now about 5 or 6.
What was she?
Well, it was on that figure. I mean, the fact is, she had mycophenolate, she had lots of IVIG, I mean, it's the usual, nothing special. You just tailor it to the patient and whatever you can give. And in the UK, you can't always give them these things. You can't afford it. So this is a disease which is much more common in young people, as you'll probably know, particularly young adult females, but also children. And even in children, it tends to be more females than males, but you do get children, little boys of 1 year old getting this disease. The youngest patient we're aware of is 8 months, I think. So this is a disease that can occur in babies. So the Nmda receptor antibody encephalitis is relatively common in children. It presents mainly with behavioural abnormalities and seizures, sometimes with the movement disorders early, but often that occurs later. So it's the behavioural abnormalities that you have to be sort of thinking about this disease, which is obviously difficult. And the tumours are very uncommon in these small children. Now, am I allowed just another couple of minutes? because I did want to show you this just because there's a child case. This is obviously an adult. But this is a patient who has glycine receptor antibodies, and he has initially a very severe startle reaction, as you'll see. He's completely unable to control that startle response, but it's not psychogenic. And in fact, it's very, very quick, much too quick to be conscious. And then he became very, very sick. So he had a form of stiff person syndrome plus, or you can call it progressive encephalomyelitis with rigidity and myoclonus. Retrospectively, we identified glycine receptor antibodies in this patient. It was the first patient with those antibodies. And he made a substantial recovery with immunotherapies and went back to work. But unfortunately, 5 years later, he relapsed. But he's been retreated and he seems to be okay. So this is very rare, but it's a fascinating syndrome. And there's a little child whose case is in fact just online now in JAMA Neurology. Archives of Neurology has become JAMA Neurology, and that's where you'll find it. I need to put this on. So let's just go. Right, listen. I hope you. Right, but whenever there was a beep, and she reacts almost before the beep. You can see her startle, and then she stiffens and cries. And now she's having another reaction. And you can see how her legs become hyperextended and very, well not hyperextended, but very rigid. And she begins to go blue and her eyes begin to go all over the place. She gets sort of myoclonic jerks. So she had what was really a sort of rather relapsing, remitting course of a encephalopathy. Which, as you can see, was very frightening for everybody. Now she's relaxing again. So this is her course. She had 2 relapses within 50 days, and then she went home on relatively reducing steroids and a bit of IVIG. And in fact, every time she got an infection or something, it just relapsed again. Although the relapses got less and less as she was treated, and she's still receiving IVIG some time, almost 3 years down the line. Here are her antibodies to glycine receptors. There's the green cells, here's the red around the green cells, and both together. But her antibody levels have come down, and she does seem to be doing very well. The video would show her actually recovered, walking down the stairs and singing a song, and she seems to be fine. These patients are interesting because they have a combination of brainstem, spinal cord, and autonomic disturbance. And they are, again, very rare so far, but as always, when you have an antibody test, you begin to find less clear phenotypes, but hopefully help patients with a wider expression of disease. And this is the study that we've just published, which has just come online in JNMP. And the point I want to make in this study is twofold. One is that within the UK, if you look at patients with autoimmune encephalopathies, children with autoimmune encephalopathies, only about half of them are Caucasians. There seems to be far more Asians and Black and other ethnic groups involved. So I think, if anything, you're probably going to have more patients with these diseases than we do, relatively speaking. And among the 48 patients that we identified in this study, 13 had an Nmda receptor antibodies, 7 had potassium channel complex antibodies, and the remaining 28 were antibody negative, but they also responded to treatments in very much the same way. So basically, we believe that there are more antibodies to be found, and that one should probably consider treating quite aggressively any patient in whom you have excluded other forms of an encephalopathy. Because of time, I'm just going to end with the summary. There's a growing number of these antibodies in CNS diseases. Presentations are very wide. Some of them are monophasic, others may be more chronic, like Neuromyelitis Optica. And I'd like to just thank my colleagues, and particularly the pediatric people who are now working with us which has been such an advantage and really very exciting to be working so much with Ning and Neil and Suki, who are two clinical pediatric fellows that work. Thank you.
Thank you very, very much, Dr. Vincent, for a wonderful talk, and I enjoyed it thoroughly. And I don't know about you all, looking at some of the videos, I think I had a patient just like that, but I didn't do the testing or think of the diagnosis. So I think we learn more, we will be able to do more. I think while we are switching and moving to the second plenary talk, we can take a couple of questions. If anybody has,